Hello, everyone. Good afternoon. Welcome to this webinar on the right to health under medical apartheid. This webinar is part of a campaign that we are running with a number of BDS groups all over Europe against the complicity of AXA in human rights violations in Palestine. Before we begin, just a small technical announcement. For those who want to follow the webinar in French, we managed to organize translation. At the bottom of your screen, you will find this globe and you can choose the option translation to French. My name is Jasper. I am an activist at Intel Globalized Solidarity. Intel is a social movement in Belgium with groups all over the country, organizing activities, setting up campaigns, joining actions for a more just and social world. Now, as you might have noticed, these last couple of weeks, we have been flooded with news about the vaccines, the COVID-19 vaccines, about the vaccination campaigns that are ongoing, of course. And one of the countries that the mainstream media has been promoting, has been hailing, is Israel. Israel has been hailed as the world leader in vaccination at this point. According to the news articles, Israel will have vaccinated most of its population or all of its inhabitants by the middle of April. But what these articles are missing out on, of course, is two things. On the one hand, just like many other rich countries in the world, Israel has participated or engaged in these bilateral purchase deals for vaccines. So that means that they have basically bought up the existing supply of COVID-19 vaccines. And this, of course, has limited access for poorer countries, for lower income countries all over the world. Now, on the other hand, while Israel is vaccinating 750,000 illegal Israeli settlers on the West Bank, it is refusing to grant access to Palestinians that are living under its occupation. So 5 million Palestinians that live in the occupied territory have difficulties accessing COVID-19 vaccines. And this despite the obligations that Israel has as an occupying power under international law. So I think that once more, this discussion, this issue illustrates very well what it means to live under occupation, what it means to live under a system of apartheid, and this is the topic for today that we will be talking about. We will be talking about
Aujourd'hui. Nous allons parler
Israeli apartheid, of Israeli occupation on the health of Palestinians, on the ability of Palestinians to organize and set up a decent public healthcare system. And we will be also talking about the campaign that we are running, the AXA campaign and the complicity of AXA in this system of apartheid. So we have invited two speakers today. Uh, First of all, we will be speaking to Deepika Yoshi. Deepika has been working in Chhattisgarh state of India on issues of health system strengthening, the social determinants of health and indigenous health through research, campaign, and community engagement. And she's associated with the People's Health Movement, the India Right to Food campaign, and People's Union for Civil Liberties. Deepika will be explaining why a public healthcare system is crucial in the fight against the pandemic, a system that is in public instead of private hands and that is accessible to everyone, of course. And she will be talking about what a strong public healthcare system looks like and zoom in on how it helps us in the fight against the coronavirus. Now, secondly, we have invited Yahya Abu Al-Rab. He is a Palestinian youth activist who is interested in working on the introduction of neoliberal policies in the Palestinian context, and he is also campaigning against the consequences of these policies, political, economic, social, on the Palestinian people. And Yahya will be talking about the impact of the Israeli occupation and its system of apartheid on the health of Palestinians, how it affects the Palestinian public health system, and what this means for the management of the pandemic and the distribution of COVID-19 vaccines. Now, after Yahya, I will dive a little deeper into how AXA supports Israeli apartheid. I will talk about the campaign, some milestones that we have reached, and how you can get involved. Before we start, just one more technical announcement. We will have some time at the end of this session for a Q&A, for questions, for discussion. So don't hesitate to use the chat box to share your ideas or just to say hi to other participants like Ubay already did, I've noticed. So Deepika, I will give the floor to you now to hear from you what a strong public healthcare system looks like and why this is so important in times of a pandemic. So Deepika, I give the floor to you.
Thanks, Jasper. Do you see the PPT?
Yeah, we can see it. Perfect.
Thank you, and good evening and good afternoon to everybody and all the BDS activists and all the health movement activists. Thank you for organizing this webinar on this very important issue and also for having PHM here. I have been told to keep explain how a well-functioning, strong, robust, and a caring health systems looks like, and I'll try to keep it as simple as possible. I will start from talking about the theoretical frameworks, how they envisage an ideal health system, and also how the social determinants of health framework, which brings into aspects which bring into deeper aspects of structural determinants of health. I will go on to talk about the aspects of good health systems. I will also talk about one of this case study from my own state from these conflict affected districts, which has managed to do quite well through improving certain aspects of health systems, and eventually what our demand should be as social movements to demand well and strong health systems. So these are, I'll talk about these couple of frameworks. One, you don't have to understand it. It's basically just to get a basic idea. The first one is the building blocks framework of health system. It talks about what elements go into into a well-functioning health system. You have the service delivery, you have the input aspects, which is the health workforce, which is your human resource from community health workers to your specialist doctors. And you have the financing aspect of it. Who finances it? Where does the funds come from? Is it coming from the state or private community, or is it coming from donor organization, or is it coming from a patient's own pocket? So ideally, what we demand is the financing should be from the state. The money raised through taxes. You have the service delivery aspect, which is more of an output and outcome of the health system, and also the access to essential medicines, which also includes vaccines and treatments and other technologies. And you have the overarching, the fifth and the sixth, the health information systems and the leadership and governance, which are more like overarching aspects of these which sort of guide the health systems. You have certain desirable attributes of access, coverage, quality, safety, which I'll go on to talk ahead. And eventually what are outcomes, what should be from good health systems. However, this is the health systems building block framework. If you talk about the social determinants framework, again, it's okay. This is just, I mean, one just has to understand, one doesn't have to get all the arrows and all whatever it's written. Eventually, the health system framework that I earlier talked about forms only one aspect of this overall framework, which determines a human being's health. It's like the tip of an iceberg where the health systems lie. And you have these underlying aspects of structural issues, which this is pretty much self-explanatory, where you have the socio-economic and political context, what policies the government has, how is the governance like, what is the polity of the country, leadership, etc., which eventually go on to determine an individual's socio-economic position, what will the person's education be, what will the occupation be like, whether or not that person has employment, whether it's in the formal sector, informal sector, whether you have the minimum wage or not, etc. and which eventually will be mediated by your gender, your ethnicity, and your other social caste and social class and caste, and which eventually will go to these intermediary determinants, the closer determinants of where I live, how much money do I get, what are my behavioral factors, what are the psychosocial factors, which are very much, which are not individual to say, which are very much determined by the structural factors that we talked about on the written on the left hand side. This mediated by the health system here, right here, eventually will go on to determine an individual's health. So these are the two frameworks that one can keep in mind. And while we go on to talk about how do well-functioning health systems look like? Well-functioning health systems have to be universal. They have to be available to all, regardless of person's gender, identity, citizenship status, refugee status. They have to be free at all points. There should be no user charges, no minimum charges when you enter the hospital or buy medicines or take certain diagnostic tests. They have to be free at all points. They have to be financed by the state, because there's enough evidence now to say that markets cannot take care of population health, and states have to eventually take responsibility for equitable health systems. Good health system will focus on comprehensive primary health care. It's important to talk of primary health care. When you talk, the pyramid that you see here, the primary level, the blue, this is where most of the population health needs lie. And this is where most of the focus needs to go in. And this is where the governments need to focus the most. After which you have the secondary level of care, which is slightly specialized care of needs, like an eye surgery, etc. And you go on to tertiary level, where very less percentage of your population will have these needs. So super specialty operations, which probably many countries may not have, and they may have to go to neighboring states to get these services. So it's very important to have a focus, governments focusing on the primary and the secondary level, which also ensure that your diseases do not advance to reach the tertiary level stage. So if you have community health workers screening you for cancer or for non-communicable disease at your village level, it will ensure that your disease do not progress to reach the tertiary level. So there's a need for governments to focus at the lower level. They need to be, other very important aspect of health system has to be the 3 A's, availability. They have to be available in the first place. They need to be accessible. They need to be available close to my house or closest to my house. They cannot be in a city 500 kilometers from my house. As much as possible, they should be equitably distributed. They should not be concentrated in one city or one town or certain or in a region where a certain population, let's say rich income population lives, etc. They should be equally distributed, and where the need is more, where the vulnerable population is more, there the accessibility needs to be better. And of course, affordability. They should be, the population should be able to afford it. We demand that they should be free at all points. Equity, very important aspect of health system. Health systems are also means to enhance, to progress equity. So for example, having a health worker from, having a doctor, getting a doctor from a neighboring country, from a very well private hospital, is good for my health and for the hospital next to me. But even better is the government ensuring that someone from my community gets the medical education that he or she needs to get through scholarship, and that person from my community through state resources serves me close to my house. So that's the second option, is higher on equity parameters, where the health systems are not only ensuring services for the population, but they are also ensuring employment. They're also ensuring that the same community person is serving the population, etc. Intersectoral action is very important, where it's very well known that you need to coordinate with other sectors in the economy, whether be it the nutrition, when it comes to indigenous health, forest departments are very important. You have the child care services, you have the women and child department, etc. So convergence across departments. Certain countries have these policies where all the departments have this policy about health in all departments, where they ensure an aspect of health in every department. They need to be participatory. Community needs to have a role in designing and determining what health systems they get. They need to be sensitive and ensure that they meet my cultural needs, etc. And eventually the social determinants of health focus, where they are also, where the health systems also take into consideration the larger structural determinants that we talked about earlier. Now, there's a very common excuse that is given by countries, whether countries or private organizations, that the low and middle income countries are low on resources, they cannot improve their health systems, etc., which is true to an extent, that these countries are low on resources and a lot has to be done because of the history of colonialism, etc. But we have also seen examples where from these countries, from these LMIC countries, many countries have been able to do very well, have been able to build very strong health systems with strong primary healthcare approach through sheer political will and allocating budgets and resources from within their revenues, etc. So you have had examples of Thailand in Southeast Asia. Within Africa, Rwanda is seen as an example which has built its health system strongly. We have example of Sri Lanka, which has a very strong primary healthcare approach. This was also seen when everybody was surprised to see how many countries which were not seen very high in, which were not really known for their health systems, happened to do very well in the COVID pandemic. So we saw Thailand doing very well in the COVID pandemic. We saw Rwanda doing very well. We saw Vietnam, Sri Lanka doing very well. So there's an entire article that has been written by one of our colleagues, that why countries which were much richer, higher on income and resources, countries like US or UK, performed the poorest in the in terms of their response to COVID pandemic. So the idea behind this is that there's no rocket science to getting good health systems, and it has been done, and it can be done through certain
de donner certaines ressources et de mieux répartir les différentes ressources. Oui, alors il te reste 5 minutes. Très bien, je vais donner un exemple de mon pays.
And in the Southern Territory are 3 districts. These are very so-called difficult districts. These are conflict-affected districts which have been facing left-wing extremism and conflict between the state actors and the non-state actors for quite many decades. And one can only, you have to be here to imagine that how these districts are considered very difficult. They're very remote. They're geographically located in very remote location. But in last few years, we have seen that how through the intervention of the state and through the initiative of the state, these districts which were considered very poor on their health system have been able to do quite well, and they majorly did it through improving the human resources retention. So human resources is a very big problem here in India, and of course across the world, where you have this inequitable distribution of human resource, which are mostly located in the cities and towns, and no one would want to work in the rural and remote areas. And the state did it through many means. It did through providing many financial incentives to the doctors, which could not otherwise be provided. So they got funds from different departments. They ensured that they tweaked the rules in medical education. So if you served in rural areas, you will get extra marks for your PG education. If you refuse to work in rural area, you have to pay up a high bond price. They ensure that this is primarily a tribal population. You have largely tribal population here. So they ensure that people from the community have certain reservation in medical colleges, and they were supported by the state to work as doctors and nurses, to study as doctors and nurses, because eventually they are more likely to stay back and serve in their community. These were most of the aspects where the state government tried to work. These are some of the examples where this is the infrastructure bit of it, where the infrastructure has improved greatly. But of course, there are times when you have very good infrastructure, you may not have the human resource and services in place, but which has not been the case here. You have had quite a significant improvement in the services and human resource in this area. So for example, specialists, this is a 10-year difference. So you've had the increase in specialists and medical officers and staff nurses. This is quite a significant improvement. This is the improvement in services over the 10 years over the last 5-6 years. This has been the improvement in terms of people who are availing services. It has been increasing. So this is a combine of all these three districts, these three tribal districts. Of course, these are my last two slides. Of course, it's very important to again emphasize the importance of social determinants of health. So, even if health systems are not built overnight, there are certain, and more often than not, there are certain other policies which go into building equitable health systems. So, for example, if you have overcrowding, discrimination in allotting houses, if you have evictions from building, etc., if the place where you are staying, if you don't feel safe around, etc., these are the social determinants. You do not expect the health systems to do much. So eventually, when we are talking about these health systems, these aspects have to be taken care of equally. What should our demand be from the health systems? We are, as activists from the BDS movement and people who have been demanding a better and more caring sort of health systems. What has to be taken care of is to ensure that your health systems are financed through state resources. They are provided through state hospitals, through government hospitals, and not through a network of private hospitals. They have to be available closest to where people live, as close as possible to where people live. They need to have a primary healthcare focus where you have a good network of community health volunteers, good network of dispensaries close to your towns and villages. They need to be available to everybody and free at all points. As activists, we also need to keep track of privatization attempts that governments have been doing across countries, and either dismantling existing private systems or trying to improve health systems through bringing in private players. So we need to very much monitor that, and eventually also whatever private sector there is, the country needs to have strong laws to regulate the private sector. This is how we can sort of frame our demands when we are also demanding for better health systems. Yeah, I will like to end there just now.
Thank you so much, Deepika. I think you very clearly laid out the basis for our next presentation, especially when you talked about that we should look at health as in a comprehensive way, that health is dependent on so many factors, on the context, the political context, the economic context that people live in, the context of our society. And this brings us, of course, to our next speaker, Yahya, who will be talking about this context in Palestine and how the illegal Israeli occupation impacts the health of Palestinians in particular. So I will now give the floor to Yahya. Welcome, Yahya. All right, great. We don't hear you though. You have to unmute, I think. Exactly. Perfect.
Yes. Good afternoon, Jasper. Good afternoon, everyone. Thank you, Deepika, for your clearly presentation. First of all, let me share my slides. Okay, great. I will take directly and in this detail about how the occupation has affected the Palestinian health system. First of all, I will first of all, we cannot emphasize enough that according to international law, providing health and other basic services is the responsibility of the occupation power. However, the Israeli occupation has never fulfilled this obligation, as we know. In fact, policies and its policies and its practices meant to provide the minimal level of these basic services, while at the same time undermined and deconstructed the infrastructure of these basic services, while at in a systematic process, usually we refer to as de-development of Palestinian infrastructure. Another fact I would like to emphasize is that establishing of the Palestinian Authority since early 90s has actually legitimized this violation of international law, where now Palestinians allegedly have their own state. But we all know that this state is just a myth that couldn't hold up this long without international funding. Worse than this, the PA didn't only relieve the occupation from its responsibility by international law, it also relieved itself from providing health services by applying a new liberal agenda and pushing its citizens to buy these services from the so-called free market. And by then we start talking in Palestine about a new form of colonization, which to say new liberal colonization as a result of the intersection of new liberal agenda of the Palestinian Authority, of our government, and the colonial practices of the occupation. I needed just to emphasize these facts before I start showing or explaining my slides. The first slide is the Palestinian health system in occupied Palestine. In regard to health system, Palestinian Authority has inherited a health system that was systematically underdeveloped during the military occupation between 1967 and 1993. Underdeveloped in every aspect. I mean, its geographical distribution between urban and rural areas, its staffing, its equipment, the quality of service, and so on. For example, of this underdevelopment of health system, statistics show that in several years between 1967 and 1993, during the military occupation, health budget for the entire West Bank was substantially lower than the budget of one Israeli hospital. The other fact about Palestinian health sector is the obstacle to develop. Despite all funding and efforts made by the Palestinian Authority and the other actors to build Palestinian health system, there are there are many obstacles to achieve this goal. In fact, for the sake of time and simplicity, I will just mention as much as I can of these obstacles as a bullet point, but I am happy to elaborate more during the discussion session. The first one is the restriction placed by the occupation on the free movement of individuals, of goods and labor across borders between the West Bank and Gaza Strip, and within West Bank itself as well. The second obstacle is the physical separation and the complicated system of permits required to travel between Gaza Strip and the West Bank.
Yahya, sorry to interrupt,
okay.
but we don't see your slides moving. Sorry to interrupt, but we are still at the first slide. If you could check that, thank you.
Okay, I'm talking about the same slide, which is the second point is the obstacle to develop.
Okay, great. Yeah.
Great, but because I didn't want to just put too much text on the slide just to make it easy to look.
Yeah, sure.
But I'm happy to mention just to continue mentioning the obstacles. The second obstacle, the third obstacle to develop health system is that also is related to the occupation, is the separation that since 2007, this separation between Gaza and the West Bank has been further complicated by strengthening the siege on Gaza and imposing more fragmentation on Palestinian health system. Now we are talking about Gaza Strip as the largest open air prison in the world. Another obstacle is the systematic destruction of health facilities. According to OCHA report, direct Israeli attacks included 452 health facilities only in the last 3 years, most of them, of course, in Gaza. Also, we can say the systematic targeting of medical and paramedical staff. The occupation full control over natural resources that are crucial to health system, including water, land, electricity. Also, especially in Gaza, because we all know that electricity in Gaza is not meant to be for 24 or 7 hours. In many days, there will be 4 hours or 8 hours of electricity, and we can imagine how this will affect the health system. So how all these violence against Palestinians and against their health system has affected under the occupation. First of all is the fragmentation of the health system. As I mentioned earlier, in the siege on Gaza and the physical separation between Gaza and the West Bank imposed a structural fragmentation in our health system. It's worth mentioning that the political split between major political parties, political Palestinian parties, such as Hamas and Fatah, has exacerbated this fragmentation in the last decade. Also, our health system is understaffed. There has been, since the PA has established, there has been significant increase in health system staffing in the last 3 decades. Despite all this increase, the shortage in the health personnel persisted. For example, we have only 1.1 doctor working in public sector for each 1,000 Palestinian citizens. Accordingly, health system is facing shortages in several medical specialties.
Donc, nous voyons qu'il y a aussi des pénuries dans les spécialités médicales. Par exemple, la neurologie. Donc, nous sommes aussi sous-équipés. Donc, les infrastructures des soins de santé sont vraiment sous-équipées. Cela montre, c'est un indicateur aussi des soins de santé. Par exemple, nous n'avons qu'un appareil médical pour 1000 citoyens. 1000 citoyens. Donc, c'est la moitié des normes internationales. Et la pénurie d'équipements est également un énorme problème depuis le début de la pandémie. Le système de soins de santé est sous pression Donc, vous le savez, la police militaire se bat contre le système, contre la bande de Gaza. Donc, ils ont vraiment surchargé notre système de soins de santé, ce qui maintient le système de soins de santé au bord de l'échec. Donc, par exemple, les attaques à Gaza ont causé plus de 200 000 blessures ces 3 dernières années. Et des milliers de personnes n'ont pas recouvré de leurs blessures. Donc, ils doivent suivre des thérapies, que ce soit physiologiques ou d'autres types de thérapies. Cela a aussi un impact sur le système de soins de santé. Cela ajoute une pression sur ce système. Et finalement, le manque et le coût très élevé des médicaments. Donc, Israël a vraiment la main mise sur la quantité de médicaments qui sont importés. Et ils doivent aussi répondre aux normes et aux obligations israéliennes. Donc, malgré les accords économiques qui ont été passés avec les autorités palestiniennes, les Palestiniens payent un prix plus fort que d'autres pays pour obtenir les médicaments. Et donc, si nous parlons des effets de l'occupation sur notre système de soins de santé, nous voyons que c'est un résultat de l'occupation. Mais la communauté internationale devrait vraiment avoir à l'œil ce point. Et je peux en parler plus longuement tout à l'heure. Alors, comment est-ce que cela affecte les Palestiniens? Alors, premièrement, les activités. Donc, nous voyons qu'il y a de nombreux problèmes d'accessibilité. Alors, l'accessibilité due aux restrictions de mobilité. Par exemple, d'après le rapport d'Orcha, en 2018, il y avait 700 000 interdictions de déplacement uniquement en Cisjordanie. Donc, vous voyez le nombre de limitations. Ensuite, problème aussi d'annulation, problème d'équipement, aussi le prix des soins de santé. Alors, le dernier problème, c'est que 60%, par exemple, est noté comme gériatrie. Cela signifie qu'ils n'ont pas d'accès aux différentes normes. Et ils ne sont pas capables de fournir des soins de santé autres que ceux fournis par les ONG. Et donc, je parlerai de ce point par la suite. Ensuite, la qualité des soins de santé. Donc, j'ai précisé plus tôt que la quantité était donc précisée et c'était largement amélioré. Et donc, on a des problèmes pour les équipements, la santé, pour jeter de l'ombre sur la qualité des soins de santé. Donc, pour parler dans ces cas. Ensuite, la différence avec la privatisation. Donc, je ne parlerai que de ces 2 points, mais nous pouvons également parler par la suite de la privatisation des soins de santé. Ensuite, le problème pour les soins de santé à Israël. Donc, j'ai déjà précisé que les systèmes de soins de santé palestiniens sont sous-équipés par la limitation des autorités palestiniennes. Et donc, cela montre que les systèmes de soins de santé. Alors, il y a vraiment des grands problèmes de soins de santé qui ne sont pas disponibles dans notre système de soins de santé. Alors, on a créé un département pour le ministère de la Santé pour gérer les problèmes médicaux, pour être traités en Jordanie, en Égypte, mais principalement en Israël. Alors, en 2018, les autorités palestiniennes ont payé plus de 1 million d'euros pour couvrir le prix de ces problèmes. Donc, ces montants ont dû être utilisés pour il y a des années. Ensuite, le problème, c'est que les autorités israéliennes coupent dans les ressources octroyées aux Palestiniens et privatisent les systèmes de soins de santé. Alors, le système de soins de santé privé qui propose ces traitements. Donc, au final, le système privé bénéficie de plus en plus de cela. Et les Palestiniens doivent payer de plus en plus pour payer ce type de traitement. Yahya, je suis désolé, il te reste 1 minute. Ok, très bien. Alors, je vais passer celle-là. Alors, première réaction de l'occupation. Alors, le traitement, nous l'avons vu avec au moment où les Israéliens ont trouvé une infection, ils l'ont envoyé, donc ils ont envoyé cette personne-là dans un checkpoint. C'est donc c'est pire que l'emprisonnement. Oui, donc il y avait la pandémie. Et donc on voit le problème créé. Alors, ensuite, la pandémie, donc ils utilisent la pandémie comme un levier. Et à chaque fois, ils utilisent l'équipement et donc à chaque fois, les Israéliens utilisent les moyens médicaux comme moyens de pression pour nous attaquer. Donc j'ai vraiment une longue liste de cas. À Jérusalem aussi, l'apartheid et les soins de santé distingués par race sont vraiment un des effets monstrueux de cette crise, de cette occupation. Donc, par exemple, ils ont envoyé donc ce cas de Covid en Palestine et dans les communautés juives. Voilà donc j'ai un tableau pour vous montrer donc la Palestine à 195 000 cas et en comparaison, donc vous voyez les indicateurs comparatifs de la pandémie, donc vous voyez donc la comparaison avec d'autres pays. Alors la chose la plus importante de la limitation israélienne que vous pouvez voir, c'est que nous n'avons que 5,7% pour 1000. D'accord, mais c'est le plus élevé dans le tableau que vous voyez. Donc, si nous comparons ces indicateurs aux autres, à la Jordanie par exemple, nous voyons que si nous augmentons, cela nous montrerait que nous arriverions au double, voire au triple du nombre de cas infectés. Merci Yahya, je suis désolé, mais nous devons nous arrêter ici et nous pouvons revenir à toi lors de la discussion.
Vaccines, for example, or other topics that you mentioned during your presentation.
Okay, thank you.
Yes.
And I'm sorry if I took more time.
Oh, it's completely fine. We do have enough time, so thank you. I think, if we look back at the presentation of Deepika and especially at the different elements of a strong public health system, that it should be clear that Palestinians, they are faced with a reality that denies their right to health, that denies their ability to build a strong public health system that is accessible to everyone. And I think you have explained very well how the illegal Israeli occupation impacts the ability of Palestinians to access healthcare, and also how the privatization of healthcare makes these things even worse. You also very clearly showed that the denial of Palestinian health rights and their lack of access to healthcare, that this is not a new thing. These problems, they did not just emerge during the last couple of months, but they are a structural part of the illegal Israeli occupation and the system of apartheid that has existed for many decades now. I want to highlight this because very often when you talk to people who never really heard about the situation in Palestine, they can be quite surprised and also angry, of course. And so a question that very often comes up during this discussion is, how is it possible that such a situation exists, and how is it possible that it has existed for so many years now? And I mention this because I want to make the link with the campaign that this webinar is a part of course. I think it's very important to understand that Israel can only maintain its oppression of the Palestinians thanks to international support. The system of apartheid, the system of occupation can only survive because the international community, businesses, artists, universities, and so on, because they continue their support for Israel and they continue to have relations with this country without questioning its behavior. Of course, there are a lot of different factors that contribute to this illegal Israeli occupation, but one of the important factors that I think is especially relevant in the context of this webinar is, of course, the complicity of companies, of businesses in violations of Palestinian human rights. We see that businesses from all over the world, whether they are based in Europe, Asia, or the Americas, that they are involved in and basically profiting from the Israeli occupation and system of apartheid. So either in a very direct way, like for example, when Caterpillar sells machines that are being used by the Israeli army to demolish Palestinian homes, for example, or sometimes also in an indirect way when an insurance company like AXA, for example, invests money in projects and other companies that directly violate the Palestinian human rights. So one example, like I told you, is AXA, and AXA is the second biggest insurance company in the world. Even it is a French company. I'm trying to share my screen now, so let me see if this works. Yeah, I think we are good. So it's active in 57 countries, and it has more than 108 million clients from all over the world. And when activists in France learned a couple of years ago that AXA has investments in a number of Israeli banks and in the biggest Israeli arms company, they launched a campaign. And what these activists have repeated over and over is that AXA is not just violating international law, but that it's also violating its own ethical code of conduct. So AXA has developed a set of guidelines, policies to decide whether it can or cannot invest in a particular company or a particular project, whether an investment is responsible to make, basically. And these guidelines, they include policies about companies that produce controversial weapons, for example. The guidelines talk about human rights, they talk about the environment. But despite this ethical code and these guidelines, AXA nevertheless invests nearly $7 million in 3 Israeli banks. And what is striking, what is surprising is that between 2019 and 2020, these investments even tripled. So while in 2019, they were at $2.3 million, if I'm not mistaken, in 2020, they went all the way up to $7 million. And this is very problematic, of course, because all of these banks, they are listed in a UN database of companies that are involved in the illegal Israeli occupation. This database was published in February last year, in 2020. And it includes a long list of Israeli and international companies that contribute to the occupation of Palestinian land, basically. And if you would take a look at the database, you would probably recognize companies like Airbnb, TripAdvisor, Booking.com. But as I mentioned, there are also a number of banks, Israeli banks in that list. And the banks that AXA invests in, they have branches in the illegal settlements in the occupied Palestinian territory. They also give loans to settlers, and they provide financial services to governments for the construction of new infrastructure in the settlements. So it's very clear that without these banks, several colonial construction projects would not be possible. And it's also very clear that through these investments, AXA is directly contributing to Israeli apartheid and the dispossession of Palestinian lands. Now, on top, as you can see on the slide, on top of its investments in these 3 Israeli banks, AXA is also involved in Israeli apartheid in a less direct but still very clear way. So AXA owns 9.03% of a company that is called Equitable Holdings. And it used to be called AXA Equitable Holdings. They dropped the name AXA and they lowered their stakes, but still they own 9% of the company. And 2 of its senior officers even sit on the board of that company. So Equitable Holding, in its turn, invests $175 million in 5 Israeli banks and also in Elbit Systems. And Elbit Systems is the biggest Israeli arms manufacturer, known for promoting and showcasing its products as tested in combat. So the company produces killer drones, it produces surveillance technology for the Apartheid wall, it produces other parts of weapons that are bought by the Israeli army. And the drones of Elbit Systems, for example, were used during the Israeli invasion of the Gaza Strip in 2014, during which 164 children were killed. And so it's clear, I mean, AXA claims that it is not violating its own ethical conduct, but it's clear that it is profiting from its investments in companies that are directly violating Palestinian human rights. And that is why we are campaigning, of course. We are working together with groups from all over Europe to make AXA divest from these banks and companies. And AXA is feeling our pressure. So before I talk about the campaign and how it has evolved, I have to tell you something about the BDS movement, I believe, because what we are talking about today is a BDS campaign, of course. And the BDS campaign, by its full name, Boycott, Divestment and Sanctions Movement, was called into life more than 15 years ago. In 2020, it celebrated its 15th birthday, I'm sorry, and it was called into life by a broad coalition of civil society organizations from Palestine, trade unions, political parties, NGO, cultural associations from within Palestine. And the BDS movement is inspired by the South African struggle against apartheid and also by the civil rights movement in the USA. It's a coalition that fights for justice, equality, and freedom in all of Israel and all of Palestine. And what it wants to do is that it wants to pressure Israel to meet its obligations under international law. And they are the following. So first of all, Israel should withdraw from the occupied territory. Secondly, Israel should remove the separation barrier, which was declared illegal by international law. Thirdly, it should give full equality to Arab Palestinian citizens of Israel. And it should also, fourthly, respect the right of return of Palestinian refugees to return to their homes. So this is what the BDS movement is fighting for and pressuring governments from all over the world to push Israel to comply with its obligations under international law. Now, the BDS movement has grown to a worldwide movement with local groups, activists, and movements supporting and campaigning for its goals. It uses a non-violent strategy and actions. And what we see is that the movement has grown more and more powerful and has more and more impact over the years. And I think that we can see this, or that this is proven by the efforts of the Israeli government and Israeli lobby groups to discredit and criminalize this movement. Israel dedicates more and more attention to the BDS movement, and it has even established a whole ministry, the Ministry of Strategic Affairs, to campaign against the BDS movement. So this actually shows that the BDS movement has a huge impact and that it is effective in what it does. Now, it's not just the Israeli government that is feeling our pressure, but all companies involved in Israeli apartheid. And we see that with AXA as well. So over the years, and that is what I want to show you now, we managed to do some things with the campaign. There are a number of milestones. So like I told you, the campaign started more than 4 years ago in France, where activists even wrote to the head of corporate responsibility of AXA, but they got an unsatisfying response. So according to AXA Elbit, the arms company was not making any controversial weapons, but that is just not true, because many reports have proven that Elbit supplied white phosphorus to the Israeli army that was used against against Palestinian civilians, in Gaza. Now, in 2017, the French activists organized a protest at the general meeting of AXA in Paris, during which they distributed flyers to shareholders, asking them to stop financing Israeli apartheid. In June 2018, the international coalition was launched. So the campaign stopped being a French campaign, and it turned into a European coalition with groups joining the campaign in France, in Belgium, Spain, Switzerland, Germany, Italy, and in Ireland. So the campaign moved to an international level, and this increased the pressure on AXA. And that is also when in December 2018, we reached another important milestone. AXA divested from Elbit Systems. They divested from the arms company after it had acquired IMI Systems. And IMI Systems is a large cluster bomb manufacturer. But as we have seen, AXA is still investing in Elbit System through its stakes in Equitable Holdings, the company that it is still owning. So another important milestone is in July 2019. Some of Us, which is a non-profit organization that holds big companies to account, it published a report proving that AXA was still investing millions in a number of Israeli banks and in Elbit System. And this is what made thousands of people from all over Europe send a letter to the CEOs of AXA, asking them to divest from Israeli apartheid. Over 25,000 people sent a letter. And in November of that same year, there was a global day of action with protests in over 10 European cities. And despite the pandemic, also 2020 was a year full of activities and actions. In January, before the lockdown, BDS activists gathered in Berlin, in Germany, to protest the German government's repressive anti-BDS measures. And they also highlighted the demand for AXA to divest during this action. In June, just like in 2019, over 5,000 people sent an email to AXA CEOs calling on them to completely divest from the complicit Israeli banks and Equitable Holdings. More than a dozen human rights defenders from 5 countries shared videos calling for AXA to divest, and there were a number of protests in Madrid, in Brussels, Antwerp, and in Berlin. In November of last year, finally, over 10,000 people and 250 organizations, or even more, trade unions and small businesses, they signed a pledge to boycott AXA. So this means that they promised not to get an insurance at AXA. And what was great, actually, is that even Noam Chomsky, the well-known US scholar and activist, was also signing this pledge. So on top of this, the number of organizations and individuals actually also canceled their AXA insurance policies because of its complicity with Israeli apartheid. Now, even though AXA pretends to ignore us, we know that the campaign is working, and AXA is feeling our pressure. So since we started our campaign, AXA has divested from Elbit Systems. It has vastly reduced its shares in Equitable Holdings to only 9%, as I mentioned before. But despite these reductions, AXA is still invested in Israeli banks that are complicit in the occupation of Palestine and in the Israeli system of apartheid. So that means that our campaign is not over, and we will continue until AXA is completely divested from Israeli apartheid. And you can help us doing that. You can join the campaign, as you can see on the slides. You can get your organization to join the international coalition to stop AXA assistance to Israeli apartheid. You can ask AXA to divest from companies violating Palestinian rights by writing them a letter, for example, that you can find on the website of the BDS movement or the website of Intel. You can also cancel your or your institution's organization's insurance policy with AXA if you have any. And what you can do as well is, of course, join BDS groups, join local solidarity groups that are organizing protests, that are organizing actions and activities. And for example, in Belgium, the following weeks and months, we will be very active during the Israeli Apartheid Week, which takes place between 15th and 21st of March. We'll be organizing a number of activities and actions. On the 29th of April, there will be a general assembly of AXA during which there will be surely actions. And then also in Belgium on the 9th of May, there is another activity called Via Velo Palestina, and there will be a bike ride that we organize, moving from one spot to another and calling on the people to stop support Israeli apartheid. You can have a look on the Facebook pages of Intel here in Belgium, but also on the Facebook page of the BDS movement in Europe to see what is going on. And another interesting initiative, I think maybe during the discussion we will get back to it when we talk about the vaccines, but there is a citizens initiative that is being run at the European level, so all European people can sign it. The initiative needs to collect 1 million signatures and aims to free the vaccine from all intellectual property so that it can become widely available all over the world and produced at a much higher pace than it is being now. So you will probably see this link in the chat box. I would like to move on to the discussion. So let me just quickly check if there are any questions. All people who do have questions, you can put them in the Q&A tab, or no, we are not going to do it in a chat box. Just put them in the Q&A tab so we can read them there and have a discussion with the speakers. Now, one question that was already answered by Deepika, but that I would like to come back to is Dick de Graaf, who asks, why is Cuba not mentioned as a good example of a good functioning health system in a poor country? Deepika, you already answered why it was not in your presentation, but maybe could you elaborate on this in the sense, is there something that you could say about Cuba and about its health system and why it is doing a good job during this pandemic?
Yeah, like I said in the chat box also, yes, because you could only mention a few examples and it was not an exhaustive list. So yes, we have always been citing the example of Cuba as a country with much lesser resources and which has built a very robust very robust healthcare system, which is built on much more work on the social determinants, so such as education and the land rights, etc. And one of the primary example that we give is of the very strong community health workers program that they have, which across the world we have been trying to learn from. And of course also the kind of solidarity it tried to build through its medical education and through sending its doctors abroad. So yes, it was not an exhaustive list, but Dick, yeah, very much Cuba is part of the yeah, thanks.
Thanks, Deepika. I have a question for Yahya. It's in French, so I have to translate. Well, basically, this person says that there was a decision by the Israeli government which very much shows the discrimination of Palestinians, and that is that the administration of prisons in Palestine decided not to vaccinate the 5,000 Palestinian prisoners in the prisons, the political prisoners. Is this something that you could talk about?
I can say that it shouldn't be a surprise, first of all. Like Palestinians in general are denied accessing the vaccine. We in the last 2 weeks, we received only 7,000 doses for the entire, like if we counted for Palestinian and West Bank and Gaza Strip, we are talking about more than 5 million. but so far we still have 7,000. 2,000 of them, the PA trying to deliver 2,000 to Gaza Strip, but so far, the Israeli, until this morning, the Israeli denying the access of those vaccines. In the case of prisoners, like as I mentioned, it's the occupation is using the pandemic and exploiting it to its maximum to increase the punishment and to exploit confession from the prisoners. Another fact I would like to add that as Palestinian has been denied from vaccines, that Israeli authority as well announced and invited all international individuals living in West Bank or Gaza to come and have the vaccine in their health system, and still we are denied. So if Palestinians who supposedly to be free in West Bank are denied, then yeah, it's not to surprise that the Israeli denied the prisoners. In fact, they are doing more than this. They intimidate them by the virus itself, especially in the early days. That's what I all have to say. Thank you.
Mm-hmm. I have another remark by one of our participants here that apparently a French doctor on a specific news channel talked about I think it's an argument that Israel itself has very often used to deny its responsibility to vaccinate the Palestinians under its occupation. So they always refer to the Oslo Accords, saying that, during the Oslo Accords in 1995, I believe it was, we decided that the Palestinian Authority would be responsible for providing health services in the Palestinian West Bank, in the occupied territories. And I think this is an argument that Israel very often uses, but now apparently on I-24 news channel, also a French doctor was using. Could you comment on that? Because of course you talked about Israel being responsible as an occupying power.
Exactly. I would emphasize a second time that the Palestinian Authority is not a state. It's not a state by fact on land. It's not a state by international law itself. So it's not a member of the United Nations. It's a non-member state of the United Nations. Second, on the ground, Palestinian Authority control the Oslo Agreement has, as we all know, gave the Israeli the full control over borders, over natural resources, over financial resources. So the DA it's like working as a municipality in a sense to provide the minimal level of services. If we are talking about Palestine as a sovereign state, then since 2 weeks we are trying to send 2,000 vaccine doses to Gaza Strip, and the Israeli are denying it. If it's a sovereign state, it can do that, but it can't, because the agreement itself that supposedly to create a state, it is by default crippling the Palestinian political system, which we today call the DA. It's crippled by the same agreement that it created to on the ground. So yeah, I'm not sure if that was enough, but PA is crippled in every single way to act as a sovereign state. No border, no natural resources, no airport, no ports, no financial resources. For example, every while the Israelis are, for example, withhold our tax revenues that they collect on a monthly basis, and that PA cannot even pay salaries to its employees. So, like, if we are talking about a sovereign state, which sovereign state that cannot at least pay its employees?
Mm-hmm. Thanks. Deepika, I noticed that you had a very interesting comment, in fact, in the chat box as well, on the issue of prisoners, political prisoners during the pandemic. Could you share this with the participants?
Yeah, so here in our country, where the highest court, the Supreme Court, gave orders that I think it was after 2-3 months of the start of the pandemic, that certain sections of the prison population, the under trials, those who are not convicted for serious offenses, etc., those who are there were certain conditions, and they need to be freed through various mechanisms that are available, you know, either through bail or through parole, etc. So of course many states did not follow it. Some states did follow, like for example in my state, some 3 to 5,000, I'm not sure, they released these many under trials, etc. But that was something we had been demanding, yeah. But of course, it wasn't very well followed. The court orders weren't followed very well, in fact. Yeah, it was quite, still the prison conditions were quite bad.
Mm-hmm. Thanks. One final question that was asked in the Q&A box. So Dick de Graaf asks if AXA knows or confirms that it is acting in violation of the UN guiding principles on businesses and human rights. And he also asked, what about the French laws based on these principles? So when it comes to the French laws, I'm not aware actually. I don't really know how AXA should comply with these laws, or if it is actually infringing on these French laws. But AXA itself does not confirm. It surely knows, because they are aware of our campaign, that it is acting in violation of international law. But AXA itself claims that it is not violating international law or even its own ethical code of conduct, claiming that they are not doing business with companies that produce controversial weapons or are committing human rights violations. So that is also why I believe, and like I said during my presentation, that we have to keep the pressure going. We should rally around this campaign, support it in every way possible. And also, I think for participants to this webinar, I think it's very important that you do all that is in your power to join local BDS groups, to join local solidarity groups, and keep putting the pressure on our governments, on these companies that keep profiting from the Israeli apartheid system and human rights violations. And I think it's really important that we understand that it is us, the social movements, the individuals that have the power that can change these injustices. So please go check on the website and the campaign and support it. I think that on this note we can end. There were some questions about the presentations during this webinar. We will try to send them out later this week, the presentations. So I would very much like to thank the speakers to this webinar, Yahya and Deepika. Thank you so much for being here today and sharing with us your experience, your views, and I think it inspires us very much to keep going and to continue this campaign at least. So thanks for being here. Also to all the participants, thank you. I wish you a very good evening and have a great night. Thank you, everyone.
Thank you too. Thank you for having us and giving us this platform to actually deliver this message about Palestinian health system during the pandemic. So thank you.
And a final thank you also to our translator who managed to get everything to French. Thank you.